how many people have done rhizotomy? 1, 2, 3, okay. And how many have you seen a patient with spasticity or cerebral palsy? At least on TV. So I'm just going to go over the history and introduction and then the techniques. So cerebral palsy is a disease which affects the movement and motor pathway, and most of the time it happens either during the delivery, before or after. So it's a ischemia to the brain due to low oxygen while patient is being delivered. And it is a very long life disability, and it gets worse and worse. It can start from one limb, can go to the second limb, third limb, and fourth limb. So it's a group of disorder of the group of different diseases, and movement, posture, limbs lengthening, cartilage, cognition, perception, communication, and maybe epilepsy and secondary musculoskeletal disorder. So due to issue in musculoskeletal issues and development of the bone, it also affects the growth of the patient and length of the bone and the muscles. And patient have end up with contraction and unable to move during his lifetime. The motor system, it has two major neurons. We have upper motor neuron and lower motor neurons. The upper motor neurons control the lower motor neurons. And the function of the upper motor neuron is to inhibit the lower motor neuron, not to excite. So, and the function of the lower motor neuron is to stimulate the muscle fiber. So when it's stimulating all the flexor, extensor, adductors, abductor all at the same time. So the upper motor neuron is controlling which muscle to stimulate more and which to stimulate less. When the patient has a ischemia or damage to the brain, which is upper motor neuron during the cerebral palsy or any other disease that affect the ischemia, cause ischemia to the brain, it will the upper motor neuron will not be able to work, and the lower motor neuron will have no inhibition and it will contract more and more. So if you look at the patient with the upper motor neuron paralysis versus the lower motor neuron, you can look at the patient and tell them within a second. If the patient has a lower motor paralysis, the patient will have no contraction, it will have flaccid paralysis. So you walk in and you see the patient cannot move the leg or hand or anything. So that's a flaccid paralysis, and that's typically caused by the lower motor neuron damage. If the patient have too much spasticity, it has too much contraction, that's called spastic paralysis. Patients still cannot walk or move, but it has contraction, and that's spastic paralysis, and it's typically caused by upper motor neuron lesions. So the adverse effect of spasticity includes the inhibition of the movement, inhibition of longitudinal muscle growth, inhibition of protein synthesis in the muscles, and limited stretching of muscles in daily activities, and development of muscle and joint deformities. So there are four types of spastic. One is spastic diplegia, which have two limbs involved. Spastic hemiplegia, one side of the body is involved. And spastic quadriplegia, all four limbs are involved in this patient. So if the patient has arm on one side, so if one side is this spastic hemiplegia, if the both limbs are affected, have spastic paraplegia, and if all four extremities, that's spastic quadriplegia. So the patient with spastic diplegia have a much better outcome than quadriplegic patient. So if we stimulate a sensory neuron, can we get a response from muscle? What do you think? How many people think that we can get a response by stimulating a sensory root? And raise your hand. 2. So when you stimulate, the sensory root is coming from the skin, but it has a synapse in the neuron in the spinal cord. It make a reflex. So the orthodromic sensory going to the spinal cord make a synapse with the lower motor neurons to the interneurons in the spinal cord, and you get a muscle response. So if you stimulate the motor neuron, you'll have much lower threshold than stimulating the dorsal root or sensory root, but you can still get a response for that. So about 80% of the patients with the cerebral palsy have a varying degree of spasticity, and spasticity can be evident during the first year of life, and it's relatively severe, and most often it is detected later after 1 year of the life. Again, the same thing. So treatment, so there are multiple treatment options, starting with the physical therapy, and then going to braces and casting, medication, like oral medication or pump implanted, Botox injection in the muscles. If all these procedures they fail, then the last result is the surgery. And the surgery, there are different type of surgery. One is dorsal root rhizotomy, then we have selected dorsal root rhizotomy, and then you have dorsal root entry zone procedure. So the difference between selective and non-selective is if there's no neuromonitoring or have a very bad neuromonitoring, the surgeon cannot depend on neuromonitoring, so they go and they cut 50% or 30 to 50% of the sensory root. The problem with that is we don't know which roots are bad. So if you cut the good roots and leave the bad roots, the patient will have condition will worse. So with selective, we divide every root into multiple rootlets and then stimulate every rootlet and select which rootlet is bad. And then we cut only the one which have bad responses or have bad connection. We don't so, and then the outcome with the physical therapy, it has much better outcome than the regular one. So that diagnostic criteria is important. The selection of patient is important. Typically, diplegia or spastic diplegia or triplegia patient and premature birth patient with a history of premature birth, 2 years of age or more. Patient should be 2 years or more to go to under this procedure. And based on the MRI, there should be no damage to the significant motor area in the brain, and at least 3 months in the Botox. So if you have a Botox injection in the last 3 months, that procedure is not going to work because the muscle will be paralyzed. So we need to make sure in the history, patient has at least three months done. So the surgeon, they do 1 or 2 a small laminectomy at L1, and they localize the lamina. And after the exposure, so they expose all the roots from L1, L2 to S1, and they wrap every root into a small plastic cover. I'll show you the picture later. The first thing we have to do is make sure we can differentiate between sensory root and motor root. We don't want to cut the motor roots, and so we don't want to cut the motor roots. So the threshold difference is very, very less. So if you stimulate the motor roots, you can get a response from 0.05 to 0.2 or 0.3 milliampere. But if you go to sensory root, you may get a response at higher 0.5 or 1 milliampere. The latency difference is not much, but when you're stimulating both of them, it's almost 1 or 2 millisecond difference. So if you stimulate one and you stimulate the other one, and you have the 2 windows next to each other, you can tell the difference. But if you are using the same window, you will not be able to tell it's a sensory root and motor root. I have a discussion with some surgeon, like not many times, but few times, where I said, okay, this is a motor root. The surgeon said, no, this is a dorsal root. And I said, okay, no, this is, so the threshold and the signal is there. And I'm telling you, okay, it's not me, it's the computer which is telling me it's the data. So data is telling me this is a dorsal root. And after 20 minutes of discussion and exploration, say, okay, oh, that spinal cord is rotated, because most of the patients, they all have scoliosis, and sometimes they have tethered cord. So the spinal cord is so much rotated that the dorsal roots, they are twisted anteriorly, and the anterior ventral root, they appears when you do laminectomy, they're just in front of you. So it's always good. You cannot just go and say, okay, these are dorsal root and start cutting and stimulating and cutting them. So you have to make sure, try to find the anterior root and dorsal root, ventral and dorsal root, and make a differentiate and identify them. So the stimulation options, we have monopolar, bipolar, and tripolar. For the rhizotomy, we use monopolar electrode. We use 2 monopolar electrodes, and both they work as bipolar, because if you use bipolar electrode, they have fixed distance, and most of the patient are pediatric patient, and they have very small nerve roots, And we are not even stimulating roots, we are stimulating the rootlets. So they are very, very small. So under the microscope, and we don't want them to touch to each other. So we still, the most standard is peacock stimulators, but peacock stimulator was they stopped making in 1974, I think. And all the systems, all the hospitals, peacock, they don't make anymore. I think it's like, but now we have the.
There's a place in Minneapolis that
So now they have other.
Monopolar.
Yeah. No, I'm saying that the original peacocks. Rhizotomy, now they are different. They are different manufacturer. They are making the same. It has to be less than 0.5 millimeter in diameter of the tip, not the length. So the diameter has to be less than 0.5. So the typical, if you have a big bipolar or big bipolar, it's not going to work. This is the small peacock stimulator. So they are reusable. They come in disposable now also. There's some manufacturer they're making disposable, but the surgeon they're using very, very old. They have them in the system. So we use bipolar, or you can use monopolar for recording. The typical setup is using SSCP for tibial nerve SSCP. You can do a and all the lower limb MEP, EMG, and trainer 4. You have to have a trainer 4. So SSCP, we have ulnar nerve for control and posterior tibial, and MEP upper limb for control, and forearm muscles and lower extremity muscles, including the anal sphincter. So the anal sphincter muscles are the most important. We don't do rhizotomy on S2, S3 because that's going to affect the bowel and bladder function. So we want to identify the roots. So when you're doing laminectomy, you're opening the rootlet. So once you have the response from sphincter muscle, then we know that we are at the bottom of the where we are supposed to. And then we do this rhizotomy above that level. The triggered EMG, there are two types of triggered EMG. One is monopolar and 50 hertz. So I'm going to talk later. So all the muscles, and it's all bipolar recording. So we don't do any referential recording because we want to be very, very specific. Now we also have urethral electrodes. So we are doing all the cases we are doing. We do urethral electrode. The electrode is imprinted on the bladder, on the catheter, and you can record from the bladder directly. So SSCP, typical regular SSCP. So I'm going to focus on the triggered EMG because that's, but the SSP and MEP is the typical standard SSP, SSP, and MEP protocol we use, and we have to do in all the cases. Single train, we do 1 or 200 microsecond, mostly 200 microsecond, 2.79, 3.68, and that's used only for checking the threshold of the nerve. So once we have a threshold of the nerve, we can tell this is sensory or motor, and then we split the nerve roots, and then we do 50 hertz strain. The 50 hertz strain has a 100 to 200 microsecond pulse width and frequency of 50 hertz. And the 50 hertz means ISI after 20 milliseconds. The train length has to be 1 second, so it's 50 hertz for 1 second. So and your window has to be 1 second, so you see 50 stimulation. And what we do is we can differentiate normal versus abnormal responses. And the abnormal responses are graded from 0 to 4. Anesthesia, total intravenous anesthesia, halogenated aided, we avoid all the agents, nitrous oxide. Propofol is fine as long as not more than 200 microgram, because if you have 250, 300, then it's special for pediatric patient. Then narcotics have a minimal effect. Peripheral block, we don't want peripheral block if even they want to put block, so we have to just make sure they don't inject anything until the end of the surgery. Epidural block, no epidural block should be given before the surgery. Train of 4. So again, do X-ray, dura open, sensory, motor baseline. We have to trigger EMG, regular trigger EMG, monopolar, and then 50 hertz. So those are the different type of, so this is the bottom. This is a square pulse with the 50 hertz, 1 second train, so you have 50 responses, and it's a square pulse. This is a stimulation artifact. If the response is, you see the response decreasing in size, that's called decremental, it's normal, or it's square wave, it's a normal. Those are the two normal responses, we see that. But if the responses, they're getting bigger in size, they're incremental, those are abnormal response. If they're colonic, they are You have a response, you don't have a response, or they're multiphasic, so you can see or sustained like a train activity. So those 4 are abnormal responses. So we are looking for those 4. So we don't cut the roots which have decremental or squared waves. We cut only the one with incremental, colonic, multiphasic, and sustained. It has to be very quick decision, so you cannot just sit down and think about that. And the second thing you do is you look for the abnormal response and then grade them. So grade 0 is unsustained. So grade 0 is unsustained CMAP on any muscle. If you have a response or you have no response, that's grade 0. Grade 1 is if you're stimulating L2 and or L3 root and you're getting response from quadriceps, that's grade 1, and you're getting nothing from grade. So grade 2 is if you're stimulating L2 roots and you're getting this from quadriceps and tibialis anterior on the same side, that grade 2. So the next muscle, or you get proximal or adductor muscle. If you're stimulating an L2 root and you're getting response from foot muscles, abductor hallucis or sphincter, that's grade 3. So you should not be getting response from distal muscles. And if you get response from all the ipsilateral muscles and contralateral muscle, any single contralateral muscle, that's grade 4. That means, so all these roots, while development of the patient, they have abnormal interneuron connection. So we only do cut grade 3 and 4. So anything with grade 1 and 2, we leave that. So if you have this chart, so you have a grade 1, grade 0, and the response is decremental. And the muscle, you get a unilateral response from one muscle. So these are the normal responses, we don't cut that. So with grade 1, and if you have incremental, colonic, or multiphasic or sustained, but it's a unilateral single, and these are abnormal responses, we do not cut those. Grade 2, again, incremental, colonic, multiphasic, all abnormal. And if they are unilateral or single or 2 muscles, adjacent muscles, they are abnormal pathology. It's rarely cut. It's rarely cut only if you don't have these 2, and you have to choose between the 2, then you have to cut this one. Otherwise, we don't cut this one. So if you have all 4 type of abnormal responses, and you have more than, you have distal muscles involved on the same side, we'd cut that muscle. And the 4th one is have all 4, any of the 4 abnormal response, but you get a response bilaterally, and we have abnormal pathology, so these 4 are definitely cut. So that's Dr. Park, one of his papers. So you have 2 monopolar, you have to lift the roots from the CSF, so there's no current shunting, and you stimulate. Again, this one root, and you select the rootlet, and you cut the root. Schematic diagram. So this is one root, and you divide this into 2, 3, or 4 branches, depending on the size, and then we stimulate each rootlets with a small hook, and we cut only with the grade 3 and 4. This is from one of our cases. So this is a small monopolar. The root is wrapped. All the roots are wrapped because once you have 6 roots on the left side and 6 or 5 roots on the other side, 10 roots, and then you have every root is divided into 4 branches, you have 20 rootlets. It's you cannot, it's very difficult to apprehend what's going on. So you wrap them every root, and then you open one, and the one you open, they are done, so you don't, so you can move on to the next one. So you open one wrapper, and then split into 3 or 4 branches and cut that. So again, we have a monopolar, so again, we do use monopolar, so it's more easy to make a hook. This is a typical bipolar, and you can see the size is very, very big. So you have to have a less than 0.5 or 0.6 millimeter diameter hook. Again, you have a root, sensory root, and again, they are all sensory roots. So we are cutting only sensory root, not the dorsal ventral root. So if you have, so if you stimulate, this is this is a motor response. This is a sensory. This is the sensory. This is the motor response. It has a much less threshold, and you have multiple responses, and the time difference is about 1 millisecond delay. Once you have that, then we use the 50 hertz strain. So you're stimulating 50 hertz strain, and you're getting only left. This is gastrocnemius. So that's typical grade 0 response. So you're stimulating, you're getting a response, and if you look at that, this is a sustained or square pulse. It's not incremental or decremental. That's grade 1, again, because the response is abnormal, but it's again coming from one muscle on the right side. So if you're stimulating the gastrocnemius tibialis anterior, L4 root, and you're getting it from tibialis anterior and anal sphincter, that's grade 2. Now we're stimulating the one of the roots, and we're getting response from all the muscles on the left on one side, and you can see the response. They are not sustained, or they are not decremental, so they are abnormal responses. So, and this was grade 4. So we are stimulating one rootlet at very low threshold, less than 1 milliampere, and getting response from all bilaterally muscles. This is a typical multiphasic or incremental. So you can see the response is getting smaller and bigger, but it's coming from both sides. So that's grade 4 response. So, and you have to be very, so when you're stimulating, so you just stimulate once, it's 1 second stimulation, you look at the response, it's a bad or good response, it's grade 3 or grade 4, and then grade it's grade 3 or grade 4. And then you have to have a chart. Again, this is, it's just out of clip of zone, so you're getting all the responses from both sides. So, but because it's a 450 hertz strain, so you have multiple responses. So you need to have a chart. So paper, so keep writing on a paper, because you'll go back and see, okay, which nerve was cut, which was not, so documentation. So if you have L1 have 2 rootlets or 2 or 3, you can just add that and write the threshold, the grade, and if it was cut or not cut. That's good. Video is, so just a summary again. So the procedure is, the purpose of doing the rhizotomy is to minimize, because the patient is getting spasticity because it's getting abnormal sensory input to the spinal cord, and it's causing the ventral roots to contract more and more. And we want to minimize the input. In order to minimize the input, we cut the nerve roots so patient has less sensory input. But this has to be followed by physical therapy. So the SDR complication, the rate is about 5 to 10%, and most of the complications are due to surgical procedure. Again, patient can have a permanent paralysis of the legs and bladder, can have permanent impotence if the nerve roots are affected, sensory loss, numbness that's severe enough to not feel anything more than in legs, wound infection, meningitis, can be controlled by antibiotics, leakage of the spinal fluid through the wound, also repairable, and the surgical team watches very closely post-operative. So these patients are watched very closely, and most of the complications are typical because you are cutting the roots, so risk of paralysis. So you have to have sensory SSAP and MEP running at the same time, but doesn't mean you're going to get. So you may not get anything because the gray matter is already affected, so you may be able to get just subcortical response and no cortical responses in this patient. So in conclusion, SDR is a very good surgical option to reduce spasticity for the patient with cerebral palsy who are not treatable with Botox and other medical conditions. The good patient selection and good physical therapy and the good family support are the prerequisite for success. So you cannot just go and do a rhizotomy and have a good patient outcome. And reduce risk of spinal deformity in later age. So if you do the in early age, so it helps in decreasing the development of the more spinal deformities or scoliosis in later age of patient. So intraoperative spontaneous EMG and trigonometry can be effectively used to guide the surgeon in selecting resectioning abnormal dorsal root and also preventing any damage to the ventral root of this patient. So I don't have time, but I'm just going to touch on spinal cord mapping. So spinal cord mapping is done for mostly a patient with either there are 2 conditions. Either patient they're going into for spinal cord tumors or stimulator implants. So if you're doing spinal cord stimulator, then the surgeon has to do a myelotomy, which is make a cut in the spinal cord in the middle and move the 2 dorsal column on each side and go inside the spinal cord and take the tumor out. In order to do that, so he need to have a safe entry zone, because the tumor distorts the anatomy and the dorsal column is shifted on left side or right side or scurvy. So if you make a cut, you can cut through the dorsal column and have no sensory function postoperatively. So, and the second, so in order to find the, just like a cortical mapping we are doing for finding the central sulcus, you have central sulcus in the spinal cord. You want to find the midline, which is the safe entry zone, and also find the motor tract because you don't want to damage the motor tract. And for the spinal cord stimulator, we want to see is the left side or right side. So we have to identify the left side and the right side. And for the mapping, again, you want to have a distance from the corticospinal tract and have we have to differentiate between mapping and monitoring. Mapping is you are just doing stimulation and you're just waiting, and monitoring, and when you're doing continuously, you have a grid on that, and you're recording from the grid, or you're stimulating from the grid. So the normal anatomy is distorted. For the spinal cord tumor, again, we do epidural D waves. That's another lecture. So you can, because MEP, every time you do a motor evoked potential, patient is going to jump. But if you do a single pulse epidural recording, patient is not going to move. So you can do non-stop every second. It has to usually do per second 1 hertz stimulation, or 0.5 or 2, 0.5 hertz stimulation. Maximum after 2 seconds, and you do continuous MEP, patient doesn't move, and you can stimulate 200, 300 volts without any effect. So if there's a change in D wave epidural recording, you can stop the surgeon and run MEP and see that, because every micrometer can have a change in that. For the spinal cord stimulator implant, most of the time, if you ask somebody what are they doing, they're just doing a spontaneous EMG, but spontaneous EMG is not enough because placing the spinal cord stimulator is done for the patient who have gone through multiple surgeries, and they have typically failed back surgery syndrome, that they have surgery 1, 2, 3, and there's no pain relief. So you want to implant a grid on the spinal cord. It can be implanted on the brain. We have done monitoring for the brain too. Patient with severe pain in the face, or for the trigeminal pain, we can implant on the grid on the pain and cause paresthesia or numbness in the face area. So you can do mapping for that too. So for the spinal cord stimulator implant is different monitoring from lumbar, thoracic, and cervical. In lumbar area, you do typical SSCP, and you can do SSCP and MEP, and then can see changes due to laminectomy or anything. But we have to have a trigger EMG, and trigger EMG is not a regular 2.700. It has to be more than 100 or 200 hertz stimulation. And many times the implant people, they are there, so they are not using the correct stimulation parameters, and don't get response. So you have to have about 110 to 200 hertz stimulation, and you can get a very good response. If you're doing a mapping, putting a spinal cord stimulator on the thoracic and cervical level, then you want to identify the left side and right side. And there are a lot of publication on collision study to find, are you on the left side or on the right side? In order to do that, so you put the grid on, you turn on the stimulator, which is a battery connected to the, is an external battery connected to the spinal cord implant, and you run SSCP. If there's a change in SSCP, cortical SSCP, that means they're colliding and it's minimizing. And if the left side change, you're on the left side. If the right side change, you're on the right side. So you can move the grid left side. And you can run MEP at the same time. So you turn on the stimulator and run transcranial motors. And if the amplitude drops, it will never disappear. It will drop in amplitude. And you can localize the left side versus right side. So the last thing you want to do is you implant the grid on the left side. Patient has a pain on the left side, and patient wakes up numbness on the right side, on the other side. Or patient has severe pain in the toe, and patient cannot feel his groin post-operatively. That's it. Thank you.